Idag croeso I cyfarfod bwrdd iechyd. Ni hoffwn i dechrau os gwelwch yn dda. Dwi'n mynd drio cadeirio yn cyfarfod yn ddwy ieithog heddiw. I'm going to try to chair the meeting bilingually today. Dan ni'n recordio I cyfarfod heddiw. We are recording the meeting today at my cyfarfod yn cael ei ffrwyddio fwy. The meeting is being live streamed. Can I ask that members on their first interjection in the meeting introduce themselves in Welsh and English, please, as we did last time. Diolch. I start with welcome introductions and apologies for absence. I have apologies from Chris Stockwell, from Teresa Owen, and Robert Aidenstadt is representing Teresa. Hopefully, Robert, I've got the pronunciation right. Sue Green is also absent, as is Sue Hill. Jason Brannan is representing Sue Green. And on that note, can I welcome Steve Webster, the Interim Director of Finance, Rob, and Jason to their first meeting with us. Thank you for being here and representing your executive team members. The next item is any declarations of interest. Are there any declarations of interest to be recorded, please? Claire.
Bore da pawb, dwi Claire Budden, Cadeirydd Stakeholder Reference Group. Good morning everybody, I'm Claire Budden, the Chair of the Stakeholder Reference Group. I have two declarations of interest this morning, Chair. The first is in relation to the estate strategy. One of the buildings that Betsy Cadwallader uses is in the ownership of my organisation, Clwyd Allen. And secondly is in relation to the unscheduled care report and the scheduled care report. A group of housing associations across North Wales have submitted a proposal to Betsy Cadwallader Health Board to help deliver step up and step down facilities, and my housing association is one of a number of associations who've put that proposal into the Health Board. Diolch.
Diolch, Claire, and they are noted. Any other declarations of interest? No, okay, the minutes of the last meeting is the next item, item 3. Are you happy to approve the minutes of the 24th of November for the public meeting?
Yes.
Yes.
Thank you. The next item is the action table. I will take this as read and as a consent item unless colleagues got any particular issues they wish to raise. There are some updates that have been addressed outside of the meeting, including an update in the operating model and the appointments to the key posts in that model, which was circulated this week. Are there any comments or issues that anyone wishes to raise in terms of the status of the action table? No? Okay, thank you. We then move on to the next item, which is the patient's story, which I think, Angela, you and Matt will, as usual, introduce.
Yes, diolch, Mark. Angela Wood, dwi cyfarwydd y gweithred ôl nyrsio a bydreiaeth dwi. I'm Angela Wood, Executive Director of Nursing and Midwifery, and I'd like to introduce the patient story. Matt Joyce will assist me with this by running the video, and then we're happy to take questions after that.
Hi, my name's Jack and I'm 12 years old. I'm here to tell you my story about my hyperthyroid and my needle phobia. I have to take blood tests and tablets every day and 6 months and often. And one time after lockdown, I didn't take it for more than a year and I came in, but I was brave, but then I moved a little bit, so they had to take it from my finger instead of my hand. And then I came back the next time, and then I was anxious and I didn't have any of it. I was just scared and worried that I would hurt and like looking at it, getting in, like looking at it, like them doing it and stuff, and it just worried me. But then the nurse was kind to let me have another chance to do it again. Her name was Fion, and she helped me a lot to only think about that, just don't think about it and just think about positive and what I'm gonna do after it, if I'm gonna get a treat or anything like that, basically. So I came with my dad this time, and I did it eventually, and they showed me that I only have to think positive thoughts and not negative. If I had to come back in again, then I would more think positive and no think negative or overthinking it way too much. That, like, you need to don't rush them and take their time and help them realise that it's not that bad or anything, and to not overthink.
And that concludes the patient story, board members. And just like to thank the opportunity to present it. If I may just make one very short point, this is the very first digital patient story we've captured with a young person. And I think it's absolutely part of our commitment to make sure all of the voices of all the people we serve are heard, including children and young people across North Wales. So I'd like to thank Jack for being very brave and taking the time to share his story.
Thanks, Matt. And if I could just add, obviously, quite a simple patient story to demonstrate how we're supporting young people. But I think the ethos of communication and actually meeting individual patient needs, whether they be a young person or an older person, make sure that their experiences with us is positive, and that the knock-on effect of us not addressing it at an early age could actually prove really difficult for Jack. In his later life, he's got long-term conditions that will need to be managed, and now he feels positive coming into hospital rather than avoiding it, maybe not getting the treatment he needs going forward. So thanks for Jack, but certainly Fion is demonstrating the values of Betsy and making sure that she's providing the best service to our patients. Thank you.
Thanks both. Any questions or observations? Lucy.
Bore da, Lucy Reid dwi Isgadarith. I'm Lucy Reid, Vice Chair for the Health Board. Thank you for that story. I think it really highlights how important it is to communicate and show compassion to the patient, which is a lesson based. Well, it's something we should be expecting across the entire organisation with every patient contact that we actually have. And I think it's great that Jack was able to share his story with us like that. I just wonder though whether there's more we can take away from this. The story is very centered on a member of staff and Jack. For me, there's wider lessons in here. One of those actually is that the use of pet therapy in relation to trying to help particularly children, but others as well, in getting over their phobias. I've seen very successful programs in other hospitals where, you know, children going through chemotherapy, for example, they've had a dog with them to actually help go through that process and help calm them. It's shown dividends in relation to how children have then been able to deal with extremely stressful situations. So not just a needle phobia, but actually, you know, the wider context of the care and treatment that they receive. Can we look at some of the opportunities across the health board to be able to provide that support, so we're not so reliant on an individual? I don't mean that to take away from you know, the way Fion dealt with Jack, because you know, clearly it's made a huge difference to him and will impact upon his life later on. But I just think there's more to learn here.
Thanks, Lucy. Yes, I completely agree with you. We're going to be using the examples within our training. As I've discussed at QSC around us looking at how we take that learning forward and deliver it across the organisation, so people can see those examples of good practice. We are trying to get the use of pet therapy, etc., into the organisation. And recently at Ty Llewellyn, there was some dogs that came into the unit to meet the patients, the residents of Ty Llewellyn, and that was really seen as positive, and that was very much a de-stressor and allowing them to have that interaction and as part of it's almost that part of their therapy. So there are opportunities that we can look at to bring those kind of initiatives into place, but also to use this as an example of good practice and the way we expect, as I say, the values of Betsy to be put in place across the organisation. Thank you.
Thanks, Angela. That's good to hear. We've been using dogs actually as therapy in our mental health units for a while. I'm thinking that we've got opportunities across the wider setting to use them. The mental health units have, they have spaniels who come into Heathvan, for example, and all of our main mental health units. But I haven't seen them at all or heard about them in our acute sites or our community settings. So I just think there's a good opportunity.
Yeah, I've used them in acute settings before, so we will explore that and make sure that we can use it as an opportunity.
Thanks, Angela. Thanks, Lucy. Cheryl.
Bore da, Cheryl Carlisle dwi aelod annibynnol. Good morning, I'm Cheryl Carlisle, independent member. Thank you for that, Angela. That was really good. I'd just like to say how reassuring it is to see the patient at the centre of everything we're doing. That's as it should be. And this, of course, sets the tone, doesn't it, for their future treatment, especially our children having cancer treatment. If we can get it right now and reassure them, it makes all that follows so much easier. So thank you very much, both to him and to everyone concerned. Thank you.
Thank you.
Thanks, Cheryl. And let me echo that too, if I may, Angela and Matt. Thanks for arranging that patient story, and please convey our thanks to Tom as well on our behalf. As Matt said, very brave to do that. And very impactful on Jack's part to deliver the story in the way he did, so comfortably and so confidently. So thanks to Jack and thanks to you, Sue. So I'm going to move us on, if I may, and the next item is the report from my good self, and I have nothing that I wish to report at this point by way of exception. So I'm now going to go straight on to Jill and her paper. Jill.
Diolch, Mark. Bore da, Jill Harris dwi, Breuddweithredwr dros dro. Hello, my name is Jill Harris and I am the Interim Chief Executive, and I'm happy to present my report. This report covers a number of different areas, including emergency ambulances services, particularly around the air ambulance and the consultation that is taking place there, and can I thank colleagues in our own communication team who are very much involved in this to ensure that our public are fully engaged with the options that are available to them and their voice is heard. There is also a report on the challenges and opportunities around digital healthcare Wales and the work that we are doing collaboratively with them, but it equally calls out some of the cost pressures that we are experiencing as a consequence of investments into those schemes to progress our digital ambitions. The industrial action which is included within this report, obviously, whilst we have managed the industrial action very well across North Wales, and can I thank colleagues for the work that has been undertaken there to ensure that services have remained safe and responsive during these difficult times, particularly Nick Lyons, my deputy, who has acted as gold during that time. But I would also like to ask Nick and Angela, I know there have been some updates on further industrial action that we can expect, and this is likely to be more difficult to manage as it's coordinated action across a number of staff groups. So if I may first ask Nick and then Angela if they have anything to contribute.
Diolch Jill, Nick Lyons dwi Deputy Braith Gredor Drostro ac Gweithredwr Gweithredol Medical dwi. I'm Nick Lyons, Acting Deputy Chief Executive and Executive Medical Director. As Jill says, I'd really want to recognise the huge commitment of our staff and also recognise the difficulty of those of our staff who've made difficult decisions around exercising their right to take industrial action. But forthcoming, we have 2 days of industrial action on the 6th and 7th of February. That's a Monday, Tuesday, and a time when our acute sites are particularly busy, along with primary care. And this time we are seeing both unions from within our ambulance service, GMB and Unite, with the Royal College of Nurses, the Royal College of Midwives, and our physiotherapists all exercising their right. That combined effort is going to be very difficult. Those plans are already taking place in order to meet the challenge that will give us. Inevitably, I'm afraid, board colleagues, this will mean that we have to make further reductions in planned care delivery on the 2 strike action days, but also in the days leading up to that. So over the next 2 weeks, there will be a significant number of meetings to ensure that we are fully prepared for those days and prioritising emergency and unscheduled care. But I think we've already seen, and we see that in Jill's report, that planned care activity has been impacted. And I wish to apologise to those patients whose outpatient appointments and planned surgery has been cancelled. And we will see more of that in early February. Happy to take any further questions there.
John Skenty, question. You have a question?
Yes, John Galanders, and a Bunnell Dewey, John Galanders, independent member. The point I'd like to raise is in relation to the 111 press button 2, which is clearly a very welcome service and has been coming for a long period of time. I just wonder though, now that it's presumably gone live this week as per the live date stated in the report, what level of promotion are we actually now going to be giving to the 111 service to enable people to be able to access and be aware at a relevant time when they clearly are going to be in a distressed state? So I just wonder what communications plan we've got in place at the moment. Thank you.
Thank you, John. In terms of communications, we are working with our Welsh Ambulance colleagues, and we're very keen to promote this, but equally we are conscious that we are still recruiting to make sure that this is available full-time by the end of March. So there are still some challenges here, John, but we are promoting the service, and anything you can do to help us to promote that message would be well received. But I know Helen's been working really closely on this with WAS, so it might be worth Helen giving us the latest.
Helen.
Bore da pawb, Helen Stevens dwi, cefalwydd o'r partneriad ymgysylltu y Cefarabu. Good morning, I'm Helen Stevens-Jones, the Director of Partnerships, Engagement and Communication. John, just to reassure you that we're working very closely with national colleagues. As you know, the service launched on the 17th of January and it's averaging, we understand, around 30 calls a day, with the number of those calls growing on a daily basis. No major issues reported with the service as yet. In terms of our comms campaign, the full campaign will begin later this year once all the health boards are offering the service 24/7. However, in North Wales, we've already got some Google ads, which we know have already been seen about 50,000 times, and our radio campaign with Heart and Capital FM is expected to reach around 250,000 people between now and the end of March. And last week, there was widespread media coverage across all of the North Wales titles. We're working very closely with partner organisations and elected representatives and our primary care contractors as well. And they're all supporting the launch by sharing the information. So in short, we're doing an awful lot North Wales wide, and later in the year, there will be a national push on the service once it's bedded down. So just to give you that assurance, John.
Okay, thanks very much both for that update. Thank you.
Thank you, and can I thank you again to the teams that are actually providing that service, and as Helen's described, it's been very well received. Just to update on a couple of other things, if I may, Mark, we've already alluded to the further industrial action we can expect, but we're also in an extraordinary scenario where we've got what we're terming a twindemic, where we've seen significant attendances with flu and respiratory illnesses, and indeed COVID is still there. We are still vaccinating, and I would like to get that message across to our public and indeed to our staff that we are still vaccinating against flu and COVID. And if you haven't done so, would urge people to take up that opportunity. What I would like to point out as well, Mark, is that the report was updated on the web regarding vascular services. Since the original report was written, we've had to update it to reflect the new publication date of the vascular services has been moved to March. So I just want to call that out before anyone asks the question. I'd also there was a really good news story in terms of veteran aware hospitals, which I was pleased to be a part of. And I'd also like to call out that there are a number of our staff who support veteran awareness, but also are veterans themselves. And this really is a good news story. And we were visited by Colonel Phillips at Wrexham Myler Hospital to showcase the support that's available. And that was really well received by both the veterans and indeed by the staff themselves. So I'd like to commend the small team that support that. And I'm happy to take any other questions that people may have on the report.
On that note, John C has got a question, so I'll go to him next, and then Rob's put his hand up as well. So John.
Diolch, Mark. John Conliffe dwi, Aled Annabynol. John Conliffe, I'm an independent member. Thanks, Jill. Just want to pick up on the DHCW bit. No, it's good to see that we are working closer and get a better relationship with DHCW, but they do get significant funding from Welsh Government centrally. So the fact that they charge us monies as well, and that those costs are increasing, is of concern. And I just wanted to get assurance, or continue to get assurance, that we're seeking value for money out of what we get from them.
So yes, John, I can confirm that we are having conversations with them, not just about value for money, but following on those initiatives that have already gone into place, so that we can be confident that we're seeing the benefits from them that were anticipated. Also, John, having conversations with them about where we can get the best value from their services. And I'd also like to commend Dylan, who is working really closely with them, and I have offered his services, he does know this, to be able to support some of those conversations moving forward.
All right, thanks, Jill.
Thanks both. Rob.
Good day, I'm Rob Attenstead, consultant in public health. Diwrnod da, Rob Attenstead, idw I ymgyrch horrid iechyd cyhoeddus. Just wanted to just flag up someone who's been involved in veterans health previously in my role in Public Health Wales. Just wanted to say it's an excellent development that the hospitals become veterans aware and veterans accredited. I think this is particularly important in North Wales because we do have a very high proportion of veterans in Wales, and we do have the local authority, which is Conway, which has the highest proportion of veterans in the whole of Wales. So I think that's particularly important. Now veterans status is recorded in the census. We do have some ONS data which has pinpointed Conway as a particular community with the highest proportion of veterans. So an excellent development. Thank you.
Thanks for that addition. Okay, I'm going to move this on, if I may, and thanks for your report, Jill. We'll move now to the section dealing with strategy and planning, and we'll move to the board assurance framework. Molly, I suggest we take this item and the corporate risk register together, please. Okay, Molly's had to step away, so we'll have to defer those two items, I'm afraid. Steve, are you ready to launch into the estate strategy? And I'll come on to the back and CRR a bit later. You're on mute, Steve.
Apologies. Dwi cyfarwydd Cyslyd Drosdo, Steve Webster. So I'm the Interim Director of Finance, and I'm responsible for estates and capital. So introducing the estate strategy, but I'd like to hand straight over to Neil Bradshaw, who's the Assistant Director for Capital, and to Rod Taylor, the Director of Estates, who've led all the work on this, just to say some brief words around the genesis of this and some of the key issues coming out of it. So I'm hoping they are on the call ready. Neil?
They don't appear to be on the call, Steve.
Okay. I'll introduce it myself then. So this is a piece of work that I know there's been a lot of quite right board push to refresh the estate strategy that was developed up to 2019. So that work was done in the autumn by an external consultancy that has gone through the PPPH subcommittee and now has come to the board. What this is really trying to do is to identify the key issues around the estate now from a perspective of the quality of the estate, some of the risk issues around the estate, how well we use the estate, and how that aligns with some of our strategic priorities, and then to draw out a strategy as to where we go from here in addressing the issues that there are. I would sort of stress that there are a number of areas where the estate is not where we would want it to be. That has arisen from limitations in capital investment over a number of years that are not entirely within the Health Board's gift. The amount of capital funding there is across Wales is a key constraint there. What we have been trying to do, and we will continue to do, is to prioritise the capital funding that we've got alongside revenue funding to address the key issues and in a priority way, but in sync with the strategy. So this piece of work, if you like, enables us to do that and to get a sort of clear as possible focus on further work in that area. So that's all I wanted to say, Chair, but obviously take any questions.
Before I move to questions, I'm conscious of the fact that this estate strategy has been to PPPH committee in the first instance. So I'm going to bring Linda in. Linda.
Diolch yn fawr, Cadeirydd. Linda Thomas dwi'n aelod annibynnol o'r Bwrdd Iechyd. Dwi hefyd yn gadeirydd Pwyllgor Partneriaethau Pobl ac Iechyd Poblogaidd. Fel oedd y cadeirydd yn awgrymu, mae'r strategaeth wedi cael ei drafod gan y Pwyllgor Ac oedd y pwyllgor yn croesawu'r strategaeth yn fawr iawn. Mae'n amlwg bod yn bwysig dros ben bod y bwrdd yn sylweddoli beth ydy'r sefyllfa ar ran ystadau. A hefyd wrth darllen y dogfen, mae'r heriau sylweddol yn amlwg. Ac felly, roedd y pwyllgor yn teimlo bydd angen i'r bwrdd ystyried cynllun gweithredol i cyd-fynd gyda'r strategaeth mwyn gweld bod rhai o'r meysydd fregus yn cael ei datrys ac hefyd a bod yna mateb iddynt. Felly, oedd y pwyllgor yn teimlo bod hyn yn man cychwyn ac man cychwyn da ar ran deall lle da ni ar ran ystadau, ond bod angen dipyn o waith mwyn i ni i dallu darparu cynllun gweithredol. Hefyd, Gadeirydd, gai jyst tynnu sylw'r bwrdd at y ffaith bod y pwyllgor yn awyddus i'r strategaeth ystadau hefyd cael ei ystyried tu fewn sgwrs ynglyn â strategaeth asedau. Oherwydd mae yna sawl maes yn fanna sydd lle mae'r ddau strategaeth angen cael eglurdeb ac ar hyn o bryd roedd y pwyllgor ddim yn teimlo bod digon o eglurdeb ynglyn â strategaeth asedau yn hytrach na ystadau staffau. Ond roedd y aelodau pwyllgor yn croesawu'r strategaeth yn fawr iawn a gweld o'n cychwyn da. Diolch.
Can I respond to that, Chair?
Yes, please. Yeah, thanks, Steve.
Yeah. No, absolutely. I mean, we can't have a strategy and just put it on the shelf and not have regard to where we go from here. So absolutely, we need a route map going forward about the actions that we'll take and how we will prioritise to address the key issues in the strategy. I think that's what we try to do through the capital planning process, but I think we need to maybe demonstrate a clearer link for the board around what those actions are and how they would impact on some of the deficiencies in the estate that there are now and over what period. So I think that's something we need to do. What I would sort of stress, though, just to make sure that the board is fully aware that within the funding system for Capital in Wales, there's a relatively low level of discretionary capital, which is totally within our gift, which we prioritise between the estate and other assets, IT assets and medical equipment in particular. So that is a fairly small sum. The larger sum is then the strategic capital across NHS Wales. And so we're prioritising, as well as service improvement, we're prioritising some of the major schemes to address deficiencies in the estate, like the Royal Alexandra scheme. But making progress on those is obviously dependent on Welsh Government approving individual schemes. So we've got a number of schemes in the pipeline, but approval of those is not in our gift. So we need to draw a distinction between what is in our gift and what we are pushing for and bidding for, if you like, but is not in our own gift. Thank you.
Thanks. Welcome, Rob and Neil. Sorry, we moved to your item sooner than expected because Molly's had to step out. So Steve has introduced the item very well, and we're already on questions. But given you've now joined us, and I'm conscious of the fact you didn't hear what Steve said, is there anything you want to say by way of context, both?
So just with respect to context, as you know, we had Board previously approved a 3-year strategy back in 2019. We appointed external consultants last year to review and refresh. In terms of strategy, we have engaged across the organisation. This strategy aligns with Living Healthy, Staying Well. It aligns with our enabling strategies and our decarbonisation plan. What the strategy does is sets out a summary of our existing estate. It provides a blueprint for future estate, and it provides a framework for implementation. I guess probably what we wanted to highlight, key risks and challenges around those areas that we know. So key ones around Ysbyty Gwynedd, Ysbyty Mair, Abergele, Bryn and Airth, the Royal Alex and Ablett. in terms of short term, I mean, we are mitigating those risks by targeting investment from our discretionary capital, as Steve has already referred to, but they are only short-term fixes. And it is reflected in our higher than average revenue costs when it comes to estate, because obviously we're spending more on dealing with operational issues and backlog maintenance. One of the things I think we wanted to highlight was within the challenge of the competing priorities and the limited resources that Steve has also referred to, the strategy does reaffirm our immediate priorities. So with respect to compliance, that's around Ysbyty Maelor, Ysbyty Gwynedd, the Royal Alex, and the replacement for the Ablett. And from a transformation perspective, it's around investment in the RTCs, investment in orthopedics, and investment in the medical and health science schools. The strategy identifies medium and long-term priorities. It provides a framework to deliver, most importantly, including prioritisation criteria and a delivery mechanism. And I think I was catching the end of what Steve was saying. So that is very much the next step. So it's setting out in terms of the next steps, in terms of this is the strategy, this is the framework, this is setting out the vision. It's got the first set of, in terms of implementation, around the first cycle of IMTP, but the subsequent cycles will then be linked to the subsequent phases will then be linked to our subsequent cycles of IMTP. So Rod and I are very happy to take any questions.
Thanks, Neil. So I'll go to Richard first. Richard.
Diolch yn bore da pawb. Richard Micklewright dwi ac aelod annibynnol dwi. Aelod annibynnol efo arbenigaeth mewn cyllid. Morning, everybody. My name is Richard Micklewright, so I'm an independent board member with a specialism in finance. First thing I'd like to say is I do like this document. It reads very well, it presents very well, it puts the necessary arguments across very well, and I commend everyone who's been involved in its production. I do have a few questions and observations, though. The first one, I guess, is perhaps more aimed at the chief executive than the estates team. Given that the cost of maintaining our estate and developing it is potentially quite significant, and given that we discussed at a previous meeting, I think it was 2 meetings ago, the fact that we as a board do not access Section 106 monies, which is money set aside by local authorities from large-scale planning applications, which is a potentially large pot of money that would allow us to develop new facilities or extend and enhance existing ones. What progress have we made on identifying a means to do that and putting systems in place? That's the first question. Leading on from this, you say in the document that this is a new version of the previous state strategy which dated back to 2019. Would you agree that in an ideal world it would be good if such documents were refreshed and renewed on an annual basis to ensure that they keep current, and would you undertake to do that in the future for us? You also reference the fact that this has been drawn up in conjunction with a number of other strategies, and you list them out in the document. I was a bit intrigued that there was no reference to the IMTP, nor to any financial plans apart from capital, and accepting that capital is a significant part of this. Given that we had an IMTP last year and there's another one under development now, how did the development of this strategy, this estate strategy, how does that fit into the IMT requirements of last year and the document that's gestating for the coming year? Another couple of questions, I'm afraid. The next one.
Richard, it's a point where they won't be able to keep up with your questions. I suggest
I'll pause.
Those, then we'll return to your other questions. I'll come back to you.
Right.
So let's pause then. So, Rod, Neil, do you want to respond to the questions posed so far, starting with the 106 question?
Yes, I'm happy to start with respect to that. So with respect to the section 106, opportunities in terms of 106 tends to be in relation more to primary care rather than, so it would be more of our primary care than community estate because they're related specifically to other developments. So we now have a process whereby when planning applications come in, they are now being reviewed and we're looking at where we have potential opportunities to take them forward. I have to say it's something which has not been in the past, I think as we pointed out, it's not been something that health within Wales generally have pursued, but it's now something on the basis of the issues that you raised, Richard, last year, we're now looking to actively do. So that process has commenced. I think we would absolutely agree that an annual review and bringing back where we are against the strategy on an annual basis in terms of progress and update will be something that we should look to do. And Claire may be raising it, but I haven't had a direct conversation, but Claire and I have had an exchange of emails about the role of the SRG in terms of also reviewing implementation as we go forward. Finally, with respect to the IMTP, so the priorities that we've identified are priorities which are identified within the IMTP. In terms of the core group that has been was brought together to develop the strategy and support the development of the strategy, Sally Baxter was part of that group, so that we're making sure that we were picking up those links. So although it doesn't per se explicitly link or state that it explicitly links, I think, as I said, the intention is that the planning cycle and the phases going forward will be linked to the IMTP, and those initial priorities are focused on IMTP priorities.
Okay, that's great. Thanks for those answers, and I'm delighted to hear that progress has been made on section 106. A significant pot of money, as I said. Just two other quick questions. On the costs on page 23, you refer to costs having gone up by 54%, cost of running the estate over the last few years. I just wondered, to what extent is that the effect of the current cost-based inflation that we live in, and to what extent is it the result of the ongoing deterioration of the estate because of a lack of repair and maintenance, which therefore presumably would necessitate more and more work and cost being associated with it. The other question relates to, on page 11, the percentages for statutory compliance and fire safety compliance, where we've set a target of 90%, but are falling some way short of it. And accepting that the figure of 90% and falling short of it is the norm across Wales. I'm just wondering why 90% is regarded as an acceptable target. And I base that question on the presumption, based on my experience of courts and judges, that if something went wrong and we found ourselves in court, I doubt that a judge would take anything other than a dim view of, satisfying only 90% of our statutory requirements and fire safety requirements. I would have thought 100% should be the goal that we're aiming for.
Rod, do you want to take the first one, because I think that relates to revenue costs?
Yes. So in terms of revenue costs, you're absolutely right. We've been impacted by two things. One is in terms of inflation, but also due to the age of the estate, we're having to spend greater elements of revenue funding on the maintenance and management of that estate. But again, inflation is a big impact. I think picking up the item in terms of budget planning and costs, clearly we've set out in the strategy an opportunity for a 3% saving year on year around rationalising the estate as well. So we recognise that there is a drive to make the estate more affordable by investing further in capital to reduce the pressures on revenue. In terms of the target on the slide, page 11, these are all Wales government targets. They're also the same in England as Wales. And I think, as you rightly say, what we're trying to do at the moment is managing an estate through a mixture of increased revenue, discretionary capital, and all Wales funding to improve those scores. And I suppose what we've been able to do over the last 24 months is, through our business case development, understand what those risks are and to be able to articulate those greater in costs, which are now replicated in the business cases that are supported in the pipeline of projects.
Okay. Thanks very much for that. I really would urge though that you reconsider the 100%. I just think that if someone accidentally were to be killed or injured and we ended up in court, a judge would take a dim view of the 10% that was deemed satisfactorily non-compliant, if you know what I mean. But thanks very much for the answer.
Could I just add, in terms of that, it also puts into a context the fact that our compliance is less than the Wales average. Part of that, because it is a return that we do on all of our properties, that also will pick up properties that are perhaps potentially vacant. So Bryn and Airth at the moment is skewing some of our figures because a significant amount of Bryn and Airth is empty, but we still have to report on compliance. So it's actually, there is no risk at all to anybody because the accommodation is empty, but it shows up in our national figures because that's the way we're required to report.
Okay. That's an interesting angle. Thanks. Thank you very much. Thanks, Mark.
Thanks, Richard. Jackie, then Claire. Then I'm going to come in. Jackie.
Jackie Hughes, dwi aelod annibynnol, Jackie Hughes, independent member. First off, I'd like to echo Richard's comments about the document. I think this is probably the first estate strategy I've ever read that I've understood. So thank you for that. It was very welcome indeed. Just a couple of points more than anything. I suppose, so I'm going to comment about the West because that's the area I know best. So I'm looking at, for example, the PCCs and looking at how they're situated in terms of the rurality of the area and the difficulties with public transport. I just think that we may need to reconsider the positioning of those or have a bigger discussion about how those are utilised. From my perspective as a person who lives in that area and understands how difficult it is to get from, for example, our house to Portmadog. You know, you're looking at least 2 buses, potentially 3, depending on the service on the day you go. And then the other comment being, and the same applies to the health and wellbeing hubs as well, I suppose, they seem to be very wide spaced and leave big areas uncovered. And then the other comment is about something that perhaps is not directly restated to our estate, but is related to how we utilise our estate in terms of staff who are working in buildings that we do not own, that are shared accommodation with, for example, the local council, but whose actions have an impact on our staff and our patients, and about when we're developing new estate, about how we make sure that we look at whether it's potentially viable to re-accommodate some of those services back within our own estate. I'll give you an example. When it was icy fairly recently, one of the buildings was closed because the school it was accommodated on couldn't open because they couldn't clear the ice sufficiently well to allow it to make it safe. But that had a direct impact on our staff and our services. So it's just about making sure that our strategy encompasses everything and doesn't just focus on on very specifically our own buildings, but make sure we encompass those bits. Thank you, and that's it.
So I think with respect to both of those, as we've said, this is setting out a blueprint and a framework, but that actually there's a lot more detailed work to do going forward. And some of the issues that you've raised there, Jackie, I think we would pick up on. The strategy also isn't necessarily identifying, it's clearly not in terms of the opportunities, identifying everywhere where we're going to have accommodation. So in terms of the accessibility issue, it's around the areas where we have opportunities and particular challenges going forward that we're looking to address. So if you look at the maps in terms of all the accommodation that we have, obviously it's far more extensive than what is shown just specifically within the opportunities. But in terms of both of the issues you've raised, that's going to be part of the more detailed work going forward.
Okay, thank you. Thanks, Jackie. Thanks, Neil. Claire, then Hugh will have the last word for me because I want to move on at that point. Claire.
Diolch, Cadeirydd. Firstly, I welcome the strategy. It's good to have a clear document in front of us. What I couldn't see in the strategy was what we'd achieved since The first one was produced 3 years ago. So I guess this links to the point that Linda made around having a really clear action plan moving forward now so that we can monitor progress. And I also welcome Neil's comments about engaging with the stakeholder reference group around that. I think we've got a really positive role to play in supporting prioritisation and then monitoring and checking back on delivery. I think, though, perhaps the more critical point I wanted to make was the strategy is really transparent, which means it's also deeply concerning in terms of the quality of some of our estate and some of the real challenges we've got. And Richard already referred to health and safety issues, fire safety issues. And it's reassuring to see that we are progressing through the kind of business case model for 2 of the major hospitals. But I guess my question is, we know that there is insufficient resources that are at our discretion to deliver elements within the strategy. And we have to make our case alongside all the other health boards for the resources which are at Welsh Government's disposal. So how do we make sure that the Betsy priorities become the top priorities which get the funding from Welsh Government, and or even more challenging, how do we influence Welsh Government to make sure that there are sufficient resources available over a reasonable time frame that brings all of our estates up to the standard that is needed to deliver great services to the people of North Wales? Sorry, a big question there, but I think that's critical really, that rather than thinking, how do we cut our cloth with what we're given, it's how do we make sure we get what we need to really deliver this strategy. Jill.
If I can perhaps start the answer to that, I think this strategy is part of that process. I think one of the things that Welsh Government have been saying to us consistently now for 12 months is, what are your priorities? And I think through this strategy and by reaffirming our initial priorities along, as I indicated previously, I think that's really important. We are one of the few health boards that have an estate strategy. And I think that we need to use this document proactively now in terms of our discussions. We need to keep lobbying Welsh Government in terms of the priorities, the fact that we have identified as a board, that we have agreed that these are our priorities that we need to progress with. And it's a question of just carrying on nagging them, I guess. Others may have a more eloquent answer.
I've got something I want to say on that point. And the first is, you will have seen that the estate strategy has attracted media coverage, and it also led to a question being asked of the First Minister in the Senate, particularly around the estate of our estates, and also the available funding, particularly in terms of capital, and the decreasing capital year on year from central government. So my question is related to the point just made, in that, are we confident that we the board, have adequately laid out to Welsh Government the scale of the challenge that we are facing in terms of, if nothing else, our inability to meet statutory requirements and fire safety compliance, which, as you all know, exposes us to risks that I think should be properly set out to Welsh Government and shared in terms of the exposure. And secondly, I think we need to start briefing stakeholders in terms of the scale of the challenge that we face in this regard, because as the report identifies, at the outermost limit, the maintenance backlog is now 350 million. And as you've more than accurately identified, our reliance on revenue to offset the declining capital and address the risks that you've described in the strategy is increasing significantly, at a point at which we've been advised that the settlement for next year is going to be very, very challenging. So much so that we anticipate disinvestment from some areas will be required. So if you put that into the mix, we are now facing a very toxic situation, for want of a better description, which will lead to some very difficult decisions being made. And I note on Richard's point that you've included in the cover sheet that the next stage is the implementation plan alongside the IMTP. And the IMTP, our annual plan, will have to be the vehicle by which we immediately consider the priorities in terms of this strategy as set against the available funding. But to come to my main point, how adequately have we laid out what I've just referred to Welsh Government, who, after all, are jointly responsible for some of the issues that this highlights? Jill.
Thank you, Mark, and I'm sure colleagues will want to come in. I know that both Rod and Neil and others have had numerous conversations with Welsh Government highlighting the risks around our estate. I think what this actually now gives us is a coordinated document that describes them in one place. So what I would suggest, Mark, is with the colleagues that are exec colleagues and Rod and Neil, that it's now an opportunity for us to set those out in a letter correspondence to Welsh Government, articulating the risks that we have across the Health Board, because clearly we've had conversations with them about individual elements of this plan. I think this now offers an opportunity to put it in the round.
Okay, so can we agree that we're going to do that? And I'd also like a stakeholder briefing document drawn up, because there is interest in this subject, as we've already seen from the media coverage, and I suspect that will increase. But in any case, we're choosing hand, I think, to share the challenges that we face and how we're seeking to prioritise the estate, which, as you all know, is often a topical subject, particularly with politicians. Steve, you're nodding. Is that agreement to do what I've just asked?
It is, and I agree with what Neil said. The strategy helps, but I think we've just, as you were saying there, Mark, there are some really hard choices, because in our strategy we're saying we want to develop and improve things, IT, RTCs, as well as addressing, the backlog and concern around the estate. So, in making our pitches forward, we're wanting both, really, but there will be some hard choices there around maintaining what we've got safely and then changing it for the better. So there is anyway, I think the strategy will help us, but we've got to confront in that there's choices between improvement and maintaining what we've got.
Okay, all right, thank you. Hugh, last question from you. Dan, I'm going to close this down. Can you put your question in the chat for me, please? Otherwise, we'll be dealing with this item for quite a while now. Hugh.
Thank you, Mark. And I think one of the key points was what Linda was saying, that there will be a working group on this to come up with a plan. The fact that it's a 10-year plan with all the risks that we've got, as opposed to a 3-year plan, highlights there is a massive shortfall of resource to deliver what we would like. So I would like to think that that working group will come up with a financial plan linked to the MTP, which reduces the risk as a priority. Because as Richard alluded to, the risks are absolutely real, and as a board we need to highlight that absolutely now. And also we can't be ambitious, can we? And I've sat listening on the other side of the coin for people from Betty Cadwallader saying they're going to invest in her Alexandra site for about 10 years and nothing's happened. And we've got to be really honest and realistic with stakeholders in terms of what the plans are. We can be ambitious, but if there's no funding aligned to that ambition, it just is not worth it. So the priority will have to be reducing the level of risk with the level of investment that we've got. And I think we need to highlight that now, but support your sentiment as well, Chair. Diolch.
Yeah. So a couple of other questions from me. First is, Rod, could you tell us where we are with residential accommodation now, please?
Yeah, so we've now completed a procurement strategy for residential accommodation. We've defined the scope of demand. We've worked and prepared the specification. and that will be due ready for consideration by the committees at the end of this month. So the procurement work that we've done is all ready and ready to go.
Does that mean we're not at a point to select a provider, Rod? We've just agreed the process and criteria.
Because it's a procurement strategy, it sets out what our specification is, what we're anticipating. For us then, once we've looked at and considered the costs associated with the procurement, it will then need to be supported by board, supported by Welsh Government, and then we can open a competitive dialogue.
Okay, and are we keeping those who've expressed an interest, Rod, informed?
Yes, we have. We've updated it 2 weeks ago, and from this conversation, I'll ensure that there's a communication that goes out this week.
That would be helpful. Thank you. Can I just then turn to what the board is asked to do this morning in respect to this document? So, colleagues, are we happy to support the estate strategy? In posing that question, I echo the comments made by Jackie and others about the quality of this document. And I express my thanks, Rod and Neil, for that. But are we happy to, first of all, endorse the strategy? Yeah, okay, I've got of support.
Yes.
The second thing is, as Neil has referred to, a number of priorities are detailed in the document. Are you happy to endorse the priorities that are set out and have been referred to by Neil on page 43 of the document, i.e. Wrexham Milo, the Ysbyty Gwynedd, Regional Treatment Centre Programme, Royal Alex, replacement of the Ablet and the Medical and Health Sciences School? Are you happy to support those priorities? That's what I'm seeking from the board.
Yes.
Yes.
Okay, thank you. So we'll await the further work via the PPH committee, Rod, Neil and Steve. A couple of actions have been agreed, so you'll need to pick that up, and I'm happy to speak outside as necessary in terms of how we handle those. And Steve, through the IMTP, which we'll come on to in a private discussion later, we'll need to consider the competing pressures through that planning framework in terms of the estate strategy and other priorities that you have identified as well. Okay, so we'll leave it there. Rod, thanks, Neil.
Thank you.
Thank you.
Jill.
Yeah.
Jill and Steve, before I move us on, the board was advised some months ago that the departure of some members of our state stream would be dealt with as a matter of priority, and there would be no loss of continuity in terms of the roles in question. I'm now concerned that the assurance that was offered by way of remuneration committee has not been met. Could you give me an update, Jill and Steve, as to where we stand?
Jill, I can if that helps. So the minute I've got in, I've spoken to them both about that. So just so everyone's aware, you know, that under the new structure, there is a Director of Capital and Estates that replaced both roles. So it's a single person. So we've initiated a recruitment process, but more critically for continuity, we've got CVs in for interims, which we're interviewing for very, very shortly. I'm not sure the exact dates, but it's in the next week or two. So there may be a slight gap depending on how quickly they can start. So it's obviously something I'm concerned about that we get filled urgently. But we're on train with that, Chair.
Okay. Jill, I think remuneration committee is entitled to a formal explanation next week. We were given assurances in that previous meeting that there will be no gap. I can't work out why there's been such a delay in the determination and filling of the post.
Steve, I'll work with Steve, Chair, to ensure that you get that update.
Thank you. Thanks very much. So I still don't think Molly is with us yet, so we'll continue out of sequence for the moment, and we'll come to unscheduled care. Nick, if we may.
Diolch, thank you, Chair. So I will take the paper as read, if I may, but perhaps highlight some key issues. And perhaps start by reminding ourselves that while the focus tends to be on emergency departments, performance metrics, ambulance delays, unscheduled care is, of course, how we as an integrated health board deliver care to our population when they most need it in an unpredictable, urgent and emergency fashion, which includes, of course, provision of primary care. We've already briefly alluded to other services such as 111 Press 2 for mental health patients. This winter has been incredibly difficult and has been perhaps a test of our plans in a way that we couldn't have predicted in the autumn. The Chief Executive Chair has already alluded to some of the issues, our 6 days of industrial action that we've already experienced, with more to come. The twindemic, flu and COVID together, impacting both on our staff and their ability to attend work, but also on admissions. And flu in particular has led to a large number of patients being significantly ill and having to be admitted to our hospitals and seeking attention from primary care. We have, and we're still trying to understand why, seen a significant increase in acuity, how ill patients are attending the emergency department, and particularly that includes self-presenters, so not just the ambulance attendances, which have been more or less steady as we would have predicted, but a large number of patients attending our emergency departments really very unwell indeed. And we've all seen, of course, in the media, the huge demands on primary care, particularly around Christmas, in relation to Strep A, with a large number of children ill, unwell with RSV, respiratory syncytial virus. So it's been a really tough time, and I'd want to recognise our staff who've been committed to working to provide that care. I think the performance part of the report, Chair, is a very sobering read for us. As our 4 and 12-hour performance, the time patients spend waiting in our emergency departments has not been as I would want it to be, with a clear impact certainly on patient experience, but also on the quality of care that we provide to our population. And I want to highlight to the board, and it's within our risk register, our significant concern about that. Within the reports, though, we see an update on the 6 Goals programme. This was the 6 priorities for emergency and urgent and emergency care launched by Welsh Government in 2021. And over the last few weeks, we've seen a significant refresh here in the Health Board about the way that we approach that. The clinical leadership of that programme is now jointly led by both secondary and primary care, because of course primary care has a significant contribution here, both in terms of helping patients so they don't need to attend the hospital, but also supporting the hospital and patients in being able to discharge patients more quickly and more effectively. I'd like to thank my executive colleagues, Angela and Gareth, our clinical executives, for taking ownership along with myself for individual aspects of the 6 Goals programme. And at the same time, we've reviewed and revised our governance and leadership and reporting around 6 Goals and unscheduled care, and now including local authorities more significantly in that programme. But also, for me, really importantly, patients, so we can hear from patients about their concerns and their worries. Within the report, we see the emphasis on the 1,000 beds project, looking to increase community capacity. Our patients awaiting discharge from our hospitals still being a significant block within our 3 acute sites, which of course has a knock-on effect on our ability to offload our ambulances. Perhaps before taking any questions there might be, Chair, I'd like to highlight some learning events that we've already planning, and perhaps 3 in particular. One is, after a really very, very difficult Christmas and New Year period, we went into heightened levels of escalation. We're holding 3 winter learning events in each of our 3 integrated health communities in the West, the Centre and the East, to really sit down with staff to understand what it was like for them, what it was like for patients, but also in the view of those staff at the front end of this work, how they feel we can do things better going forward. And I think that approach to learning is going to be really key. There's also learning for us around our emergency response, way we escalate into internal critical incident and business continuity to ensure that we do that more effectively, efficiently and consistently, but also at the same levels as other health boards across Wales. So working with other health boards and nationally to ensure that we understand and we're all doing that in the same way, because there is some variation across Wales in the way that we treat and report that. And lastly, very much a topic of the day is the hot debriefing and learning after each industrial action day, but also when we reach the end of that period, which we all clearly hope for everybody concerned is not too far away, that we sit down to really look to see what we can learn, both from the way we organise and lead the response to industrial actions, but also the way we deliver care in both our primary, community and acute care settings. So Mark, I hope that provides some sort of update, but very happy to take any questions.
It does, thank. In route question, any questions? Lucy.
Thanks for that update, Nick. And I believe actually that our performance and response to particularly the industrial action has actually been really positive. And we've done quite well in the way we've managed that. So congratulations to you and the team on that. In terms of the unscheduled care programme, I do feel a little bit of frustration in the way that we've identified some quick wins in the system that I've spoken to you and Angela about. That I feel frustration that we don't seem to be unlocking some of those opportunities more swiftly, more promptly. We've got blocks and challenges in our own processes, our own pathways that we should be able to unlock quickly. And that's having an impact then on our patients and our emergency departments. But the second thing I just wanted to say, and I know we are looking at communications plan here, but I really do think there is much more we can do as a country now, as a nation, not just VCUHB, to help our patients and public understand where they can go for what. We have now got the 111 website that has a huge amount of information and resource now for patients. So, for certain conditions, they don't necessarily even need to pick up the phone. And I'm also really pleased that we've now got the 111 Press 2 service that has been launched as a soft launch and imminently for a full launch as well for people who are suffering from mental health problems, so they can get access to the care that they need quickly, rather than having to be booked in for an appointment, etc. Particularly when they're feeling very much in crisis. So I'm keeping a close eye on that, of course, as in my role as vice chair, for how that does. But how assured are you, going back to my original point, how assured are you that we are getting to grips with some of those challenges and quick wins so that we can move that along quickly? Thank you.
Yeah, thank you, Lucy. And I'd echo your thanks to staff for the incredible hard work in response to the industrial action, but would just give a small caveat to that, or a significant caveat, that has been at the expense, as we said earlier, about disruptions in our delivery of outpatient care and planned care. And again, for patients who've had their operations cancelled, I do realise the impact that has had on you and on your families. I would want to apologise and beg for your understanding as we try and make up those appointments as fast as we possibly can. I share your frustrations, Lucy. I think there are some really obvious things that we should be able to do. Indeed, many we have done, but we can do faster. That perhaps was around the plans for our refresh of our approach to some of this work, which previously was very understandably, I suppose, centred on secondary care leadership. And I think some of the quickest wins are out there within our MIUs within our community care and with primary care. And I'm really grateful to Dr. Jim McGuigan for taking on co-leadership of this alongside Chris Subi, because I think that will help engage with primary care clusters and our community teams in order to make some of this work. I'd also think, Lucy, we need to give ourselves permission, and indeed we have given ourselves permission, and highlighted this to colleagues in Welsh governments, that there's many things that need to be done within the 6 Goals programme, and we're giving ourselves permission perhaps to do some of them, but do them less quickly in order to be able to concentrate on some of the faster acting work, that low-hanging fruit. And coming to the 6 Goals programme next month is a summary of what that refresh would look like and where we can start doing some stuff now. Lastly, in relation to communications, and I'm conscious that the expert Helen, my colleague, is on the call with me. I think generally we've been amazingly proactive in our use of social media, particularly this winter. But it has been, I think it's learning for us in response to the industrial action, because we have seen patterns of attendance at our departments significantly different on strike action days. So clearly on those days, something has been heard in a way that our normal communications hasn't been able to get the message across. So I think along with other health boards, we do need to understand whether there is some learning from us going forward. I hope that goes some way to answer your questions and address your frustration, Lucy.
Thank you, Nick.
Jill, Helen, and then I'll come to John G. Can we keep it brief, please?
Yes, thank you, Mark. It's just building on the points that Nick has made, and the underpinning direction of the primary care strategy, which will be supporting this as well. But equally, I think we have the opportunity with the IHCs. They are looking at as a cross-system landscape, as opposed to where we were previously, separating area from secondary care. So that has offered us some opportunities. And also the shared learning that we're seeing. We're seeing urgent primary care centres being developed, and some good progress made in Wrexham, which is now being shared across the whole landscape. And I know that Nick and colleagues are pulling that into the 6 Goals programme. So there are green shoots there, and I think the decisions to focus on a smaller number of things to see the pace in those areas where we get the maximum benefit is the right one.
Thanks, Jill. Helen?
Diolch, Lucy. Dwi'n cytuno. I agree completely with your point about our work with the public. We have pulled out all the stops this last season in order to really up our game, and including extra money and investment into some of the social media advertising that we can do, as well as across other platforms like radio and working with TV colleagues. Karen Higgins, who is our new Director of Primary Care, shares my view that we probably need to start thinking about a behavioural change approach. And so we're in very early stages of how we can use things like nudge theory and understanding what happens when we try and work with people in a slightly different way. So, Lucy, I'm very happy to come back and report back to you on that. It will be a longer term piece of work, but it's a different tactic.
Diolch, Helen. I would really appreciate the update, the offer of an update, and also the approach that Karen has suggested. I think behavioural change is really important for all of us, not just our public, but us here as well.
John G, scanty question. Do you have a question?
Yeah, thanks, Nick, for the update and everybody that's been working on this. A couple of points, if I may. One is in particular around business continuity planning. Clearly, it's a significant issue when you've got a plan which may be predicated on a full staff complement, and then either through illness or strikes, etc. So, first of all, it's around how you're actually been able to adapt your business continuity plan to meet the staffing. But picking up on the point that's just been raised a minute ago about communication, if you're a member of the public, the first thing is you don't recognise out-of-hours health service, and yet we constantly, even within the documents today, we talk about out-of-hours service. How do we actually move away from potentially acknowledging health is actually a 24/7 provision yes, we can't offer the same service 24/7, but somehow or other we've got to get that message over. And our thinking within the health board and health generally has got to change from what is daytime provision to what is potentially out of hours. And then, if I may, just the very final point is there is very little reference in the document regarding how unpaid carers can actually play a significant part in helping with people being discharged from hospital and the part that they play. So I would welcome a greater emphasis on what role carers could be playing within community settings and home base to get people back out through the hospital door. Thanks, Nick.
Thank you, John. I think you're right that within the emergency planning responses, the internal critical incidents, business continuity, lots of live learning. We've probably never tested those processes as often and as effectively as we have this time. And probably learning also which levers within those actually bring about change and the change that we need to. So which meetings do we cancel? Which staff groups do we call in? Which activities do we cancel in order to give the required effect? And that is already informing, as we'll see later in boards today, our winter plan for next year. I think, again, you're absolutely right that we need, I think, a greater conversation. I think Helen has already started to allude to some of the conversations that we need to be having around this unscheduled care, because whilst it's unscheduled and unexpected for an individual, we have quite sophisticated modelling within Dylan's team and within colleagues in Welsh Ambulance as to be able to predict when we will seek the peaks of care. It's been different this year, but the peaks are still happening at the same time, even if they've been higher. So I think we really need to look at being more proactive in order to prevent and address those peaks, communicating with our population so that they understand where to go at the right and get care at the right place at the right time, which of course is the heart of the Six Goals programme. And your third point, John, has eluded me because my handwriting is so rubbish I couldn't see my scrawl in response.
It was particularly around the lack of reference to unpaid carers, but the significant part that they could actually play in helping with the discharge process. So that's where I was coming from on that.
No, thank you, John. A GP's handwriting at play. You're right. And in fact, during the industrial action, we've also used carers and families to support our patients on our wards and assist with that discharge planning and also admission prevention, the term I don't really like, but supporting patients in order that they don't need to attend hospital. So I think strengthening that relationship, strengthening the expectations and being able to support people in doing that, but also, of course, working with charities, with the third sector in order that we can fully utilise some of the capacity there. And again, both locally within our health board, but nationally, those conversations happening because we're learning a lot as we go through this winter.
Thanks, Nick.
So just following up on that point, Nick, and you've referenced it several times, clearly learning is really important, and from other updates we've received during the most pressurised moments, and I'm not sure that there have been any gaps in that pressure. You've referred to the fact that things have been identified that have helped deal with the demand and the dynamics. It's important, like we did with COVID, to try and lock those in, as I think you recognise. What's your level of confidence, Nick, that we should be able to do so?
Fairly high, Mark. We've had some really good hot debrief sessions in order to be able to have that rapid learning. And the engagement, it's been really actually very positive from staff and being able to highlight areas and us being able to support them in making changes very quickly. And then people, when you can see that change making an effect, I think it reinforces that learning is worthwhile. I suppose what I think it'll happen, Mark, but not as timely as I'd hoped, is that sit back and look back time. People are so tired at the moment and the pressures are so relentless. That ability to set back in a kind of a learning workshop type environment, I think that's going to be where the real rich and soft learning happens. But we're going to have to wait till the pressures decrease before we can do that. I think within those learning events is also recognising our staff and their resilience, because we've all seen stories in the media, and those of you who walk around sites have seen how incredibly tired our staff are and overwhelmed, how overwhelmed they are at times. So I think part of the learning for me, Mark, will be how we can support our staff better next year, if that makes sense. So it'll happen, but I think that hot debrief plus the more planned learning events. Bill.
Okay, thank you. Angela?
Thank you, Chair. I just wanted to come in on the back of that one. It was what Nick has identified around the learning. So from the industrial action, the learning and moving into the next days and then future days has been really evident. Staff have been working together, sharing their experiences, making sure that any gaps that happened on one of the sites maybe doesn't happen the next time. And I think it's been really key that the team have worked so closely together. We've had the briefings, we've had the planning meetings, and then the hot debrief has identified exactly what we need to do further. So that's been really good. From a senior nursing point of view, I've been really impressed how the senior nurses have come together, looked after each other, and made sure that there's been a consistent approach. You know, I've shared with colleagues around some of the potential harms that have occurred during the industrial action phases, and it was really positive to see that we'd managed to reduce the potential harms, only having low and minor harm had happened during the industrial action days, and actually not a significant amount, which I think was testament to the care that everybody put into the planning and making sure it was delivered in an appropriate way.
Thanks, Angela. Nick, can I just then come to the section on increased community capacity and the 1,000 beds campaign? There's reference to the target of 243, but there's no indication of where we are in achieving that target. It does, of course, refer to schemes, but I'm thinking here of a indication as to the capacity that we are seeing. And I know there's a lot of activity going on, but is there anything more specific you can offer by way of update, please?
I can give a number outside the meeting, if that's okay, Mark. I haven't got the very latest number at my fingertips. I think there, of course, again, it's working with a sector that is itself already under a great deal of pressure, and where we have independent providers as well. So the contractual levers are quite complex, but very happy to provide a specific number and outside the meeting, if that's helpful.
It is. Just to bear in mind again, our local authority leads, or those who have experience of local authorities most recently, have offered to lend any support that you might find helpful in having the conversations with the local authority partners in particular. Can you, now those members have not been engaged at this point, can you and Jill keep that under review, please?
Of course we will, Chair, and I know we started to open that door in the SDG meetings that Jill has been chairing, and that I think that's an opportunity we can start to take forward at pace. Absolutely agree, Chair.
Thank you, Jill.
Yeah, just to support, I can't give you an exact number, but the percentage is very small for the reasons that Nick has defined in terms of the number of beds we've been able to access. But what I will say is that there's a meeting scheduled with myself, Nick, and local authorities, along with Mary Wimbury, as you know, represents the care home sector, to see how we can support people being discharged in a very different way, and learn some of the lessons that we had in COVID, or and reignite some of the systems that we had in COVID. So I think help from the colleagues that you described around the table, we will be hooking in. So just to support that.
Okay, thanks, Jill. So an update on the numbers would be helpful, as I say. Just to note, Nick, the information conveyed in that section in 2 paragraphs is different to the winter plan update. So I assume that's just a matter of timing. I don't think it changes the material impact of what is said. But could you also, in your further reports, keep us cited on the work ongoing in respect of the targeted care home placements, where the response from homes has been pretty low, but I note that it's anticipated that further placements will be available from additional submissions. So can we be kept in the loop, please?
Very happy to do so, Chair. Thank you.
Thank you. Thanks, Nick. Thanks for the report. And thanks to the staff, Nick, as you say, who who are dealing with considerable competing demands and have been particularly over winter. Thanks. Molly, are you now with us?
Yes, Chair. Apologies.
Can we go back to the BAF, Molly, and can I suggest we do the corporate risk register after the BAF, please?
Thank you, Chair. Apologies for joining the meeting late. So, Chair, if I may, I just wanted to highlight 3 key points which are noted in the front sheet of the BAF, and I believe you already talked about unscheduled care as one of them. So there are 3 risks highlighted in the BAF, which have increased in rating since the last meeting. And those 3 risks are relating to unscheduled care, planned care, and the financial position, all of which are agenda items separately. And I noted in our discussion on unscheduled care, for example, that we've already looked at some of the key mitigations around the 6 goals programme and some of the steps being taken to increase community capacity. So I shan't dwell too much on that, except possibly to add that more assurance continues to be received by the relative committees. And the last update we had on unscheduled care and planned care was at PFIG. And also in relation to the financial risks, those were also discussed at PFIG, and we'll have an opportunity to discuss the detailed mitigations as part of the finance report. But just to be clear, the risk specific to finance is around the ability to achieve the break-even position. And there's also a risk around savings, which is associated with that. So I just thought I'd pause and take questions, Chair, at this point, before I proceed with the recommendation.
Okay, questions, Lucy.
Diolch, Molly. So in terms of the BAF itself, absolutely welcome the update, and I know there's further work to do on this, so you know there's more reviews, etc., that need to take place. What I wanted to pick up on was the one on page 3 relating to failure to implement and embed learning. Now we have discussed this as an ongoing theme. We've discussed it at QSE committee on a number of occasions. My concern around this is the section on the controls in place to manage the risk, because it's very much focused on the raising concerns by staff. But actually the failure to implement and embed learning isn't just about failing to implement and embed learning as a result of staff raising concerns. And I'm just concerned that with this narrow focus, we're missing the wider picture in relation to learning generally across the organisation. I mean, on the point of the Speak Out Safely Guardians, you know, that's an absolutely essential role. And in fact, Jill and I met with them again only last week, discussing how we can try and increase their presence across the health board, so that people know who they are, what they're there for, and that they can contact them about anything that concerns them. And those guardians are incredibly dedicated to their role and feel really, really passionate about it. We obviously want to support them in that, but it's a wider issue.
Molly, did you want to respond?
Thank you, Chair. Yes, so I think actually the discussion that took place prior to this report in relation to unscheduled care illustrates Lucy's point perfectly, because we're talking about learning from some of the difficulties we experienced during winter in order to improve the mitigations we can apply in the future. So what I propose to do, Chair, is possibly undertake a review of the risk itself and weave in elements of learning within other existing risks on the BAF. Because I think Lucy's point is right in the sense that whilst we're talking about learning from a workforce perspective, there are other risks on the BAF which would benefit from implementation of learning. So I propose that I take away the action to demonstrate which of those risks we need to put gaps in assurance around learning, and then put associated action plans, and then report at the next committees where those meetings are taking place, if that's acceptable.
It is, yes, thank you. Claire?
Diolch, Chair. I'm just unsure now whether we're taking the BAF and the risk item together now, or should this conversation just focus on the BAF?
Just on the BAF.
Okay. Well, I guess it was more around, I appreciate that we're going to have we've got three detailed reports on the agenda with the three areas where risks have escalated. I think I firstly wanted to say this report is getting clearer, which is great, because I've been one of the board members in the past that's I guess had some criticisms about the way the report's been pulled together. But I think the thing for me that's concerning is the number of reds and the timelines and deliverability of moving to a position around risk that we're all comfortable with. And I appreciate that that's what we want to do, but I guess it's just a question about, with so many reds, the capacity of the organisation to implement change to reduce some of those risks or to mitigate the impacts of those risks. We have to ask ourselves how realistic some of the timeframes might be around doing some of that. And I'll reserve my other questions and comments till we get to the other risk item. Diolch.
Molly.
Thank you, Chair. Thank you, Claire, for that feedback about the development of the BAF. So I think I'll just answer the last question first, which was around how realistic is it to achieve some of the timelines. So we had a conversation about this with exec colleagues, that there is an end of year session, which we should undertake as a board in a development approach to review our risk appetite and risk tolerance ahead of the next financial year, aligned to some of the key plans and strategies that we're going to implement the next year. So absolutely agree, Claire, there's a need to rebase our positioning around some of this, and which is one of the reasons why, for example, the front sheet of the report highlights the three risks that are being escalated, in contradiction to our initial expectations early in the financial year that we were going to reduce those risks. So there's an element of risk tolerance and risk appetite, deviation from the original position. So what I was going to suggest, Chair, is that we actually provide an update at the March board, which takes into account where we are in terms of trajectories of implementation, taking into account what action plans we'll put in place, but also risk tolerance and risk appetite, because I think those two things are connected.
That would be helpful, and particularly given the last column is unpopulated, isn't it? Right, final question from John, and then I'm going to move this on again.
Thanks, Mark. It is a question that's prompted by the CRR report, but it does relate to the BAF, in that there's an element in there about all for Wales approach about redesigning the BAF reporting. And my concern from that is that shouldn't that be being considered by the committees and the board as a whole to make sure we get what we need as a board, rather than something that's designed on a national basis?
Thank you, John. I think that's a fair point, and I think reflects some of our discussions we've had in the past about using the BAF to suit our needs and where we are as an organisation. So absolutely, as part of the process of refreshing the BAF, we will bring in a proposal, just like we did in June last year when we had the session. We talked about the format of the BAF, we talked about how often and where it will be monitored. So that's absolutely fine as a proposal. Apologies if that's not clear in the paper.
All right, thanks, Molly. And I'll leave my hand up because I've got questions on the CRR.
Can you take it down for the moment, John? So I can. Thanks. Molly, a couple of questions for me and for Jill. So the first two items around YGC improvement and also HIW and the HIW action plan have been subject of oversight by Cabinet to this point. We do need to make a decision about whether that oversight is shifted into the committee and board structure or whether Cabinet is still required. I think we need to make that decision this week. So perhaps you could give that some consideration, and then we can discuss the three of us. The other thing from my perspective is there are a couple of matters on the agenda today that go to some of these risks. They include the estate strategy and also the finance strategy and update from Steve that we'll discuss in public and private. So, in terms of the recommendations, Molly, for this paper, can we turn to those now, please, in terms of what you're asking the board to do?
Thank you, Chair. Sorry, my Zoom stopped working for a second. So I think the first thing is, as Claire indicated, there are quite a few reds. So it's important for the board to be aware that we've deviated from our regional expectation in relation to the three risks, which are highlighted as risk 1.3 on unscheduled care, as Nick has reported on already, and planned care, which is risk 1.5, and also the failure to achieve the savings target, which has increased from 12 to 16. So that in itself then goes to the second recommendation, which is asking the board to acknowledge the fact that we are now outside of our risk appetite in terms of those risks. And that we need to be assured that we will have or have got mitigations that are robust enough to mitigate those risks. So I'll just pause there, Chair, before.
Okay, members happy to endorse that?
Yes.
Yes.
Okay. John, is that a hand up or is that a yes?
Hand up.
Right.
Sorry, yes, I endorse it, but it was that savings one that just worried me. If it's gone to 16, it doesn't sound like it's high enough, given that we are clear that we're not going to achieve the savings. Should the impact, the likelihood would actually be greater than that.
Can I suggest, John, we revisit that after a briefing that Steve is going to provide in private later?
Yeah, okay.
That's okay. Thank you. Jill, Lucy and Molly, there's another action from me arising from this document, and that's in relation to the risk at 1.6, risk of instability of mental health leadership model due to unstable temporary staffing. The update provides me with no confidence in terms of what is going on to address that risk. In fact, it details the number of interims we've got. I would like, bearing in mind this has also been discussed at Remuneration Committee, a clear indication as to what the timelines are in terms of substantive recruitment, because I think now this is becoming more and more of a concern, and I'm getting really concerned that a substantive update has not been provided either in this document or to Remuneration Committee. Lucy, and then Molly.
Thanks, Chair. I can provide an update actually now in terms of the director role that Ian Wilkie currently provides. He's working part-time for us at the moment. We've actually got shortlisting and interviews already in the diary for that. But you are right, there are outstanding concerns relating to the workforce generally and the leadership in mental health that need to be resolved. And I would absolutely support a clear update on the latest position coming to RATS Committee.
Could you pick that up with Jason, please? Liaise outside and agree what's required. It's probably going to be a verbal update now for RATS next week, but we need something there.
Yes, of course. I'll pick that up with Jason.
Thank you. Molly?
Thank you, Chair. I'm just going to highlight that for completeness. Once we have the mitigation summary, I'm proposing we circulate them to board members ahead of the next meeting, just given the scale of importance that we've discussed.
Okay, thank you. So the recommendations have been supported on that item. Molly, can we go to the corporate risk register now, please?
Shall I take that, Chair? And I'm sure Molly will want to come in and give expertise alongside. So if I take the paper as read, Chair, but perhaps highlight one or two areas. There's a lot of work done, and thank you to Phil Meakin and the team for that doing, but also a lot of work to do. Perhaps I can highlight some good practice in terms of the deep dive within the risk management group meetings, where that deep dive into particular risks, I think, helps everybody's understanding, as well as the risk owners, in terms of expression of risk and the effectiveness of mitigations, that effectiveness of mitigations being a theme we quite often see here at board. So I commend that part of the work. But I think there is a lot more work to do, as is evident both in the report, but in individual risks that I suspect we may come to. We do need to ensure that clinical risks are more effectively and consistently reflected on the corporate risk register. And that's key because it informs our investment, our strategic priorities, as well as such important areas as our clinical audit plan. So we've got to get that right, and there's more work to do. I think you could also argue that financial risks need to be more clearly represented at the corporate risk register. And there's work needed in consistency of scoring between risks across the corporate risk register. And I think that work is starting, but still a lot more work to do. I think particularly in the last few weeks, also we've recognised some process issues, partly because as a consequence of the industrial action, we've cancelled a large number of meetings. I'm afraid I've had to take responsibility for those cancellations, and particularly around risk management group, which has been cancelled. One is just about to be cancelled, another is about to be cancelled again, which I think has made us recognise perhaps some improvements in our processes, particularly around a vascular risk, which perhaps didn't receive prior scrutiny due to the cancellation of a number of meetings feeding in and ultimately up to QSE. So I think there's learning for us in that space. But finally, Chair, before taking any questions, perhaps I'd like to commend the work that's going on for the integrated health communities and the other health communities to really own risks and to be involved in this work. I think bringing those risks closer to where they're held and to have that seamless escalation up into from the level 2 to the level 1 risks, I think will enable us to have more confidence and assurance that the risks are accurate and kept up to date. And also the Once for Wales, where I recognise John's challenge. I think being involved and piloting and leading some of that work across Wales does give us an opportunity to have a more accessible platform for all staff, but also for us to shape the outputs and the access to that to inform more timely reporting. But happy to take any questions, Chair.
John.
Thanks, Mark. Thanks, Nick. No, I know your point around the national side, and I welcome our leadership on that. I think that is an opportunity for us to help influence the right direction. But my concern was that we don't end up with something that's a generic mechanism that does not address what we need as a board. I think I've got two other questions around the report. One is regarding the split of the patient records risk, CRR 2006. And whilst I'm aware of the need to split that, I was just worried about how do we get assurance that that split doesn't dilute the overall level of risk, because there's a potential that people will look at the 3 risks and go, oh, well, they're not as high, and then collectively we'd lose that overall sense of risk and understanding. Excuse me. And then the second question was around section 2.5, the risk around vascular. I just wondered from reading that whether we are being premature in approving a de-escalation of that risk at this point, given that there's still a process to go through, and we still need to have some clarity collectively in terms of how successful actions have been in terms of reducing the level of risk.
Thank you, John. And so I think there's a common theme between your 2 points actually there. I think around the electronic patient records, and Dylan may want to come in and give expertise here. But I think you're right. It's very easy to, if you go more granular, then you can lose the overall moment and impact of the risk. Or we can read into individual granular risks more than they're actually saying. So the expression, I think you're right. If you break it down too far, you actually lose sight and the overall impact is lost. I think the same said for vascular, probably. So around the specific risk, and this is something that we've Lucy led and chaired a QSE meeting last week where we explored this, and the challenge was made. The specific risk around the sustainability of our consultant vascular surgeon workforce, that has reduced because we have middle grade doctors to support them. So the expression of the risk, is that risk is significantly improved due to the hard work of the team. But perhaps behind that risk are other risks around the sustainability of the service, which by breaking down the individual, we haven't recognised. And perhaps, I would own this, John, perhaps I've used the consultant vascular surgeon risk as a proxy marker for wider sustainability issues of the service. Does that make sense? I think that's part of that wider work about saying around what we're really trying to say in risks and what it's telling us, and that we don't lose the message.
No, I understand that. Thanks, Nick. I think the key thing for any change in an area where we have recognised the significant risk to the services we deliver to the community is that we get the evidence for that assurance. No, that's the critical point, is that changes are evidenced. Of course, my general point, overall, that I'm always raising around risk is that we don't tend to actually state proper controls and proper mitigation, as they tend to be a bit of wishful thinking, or they're not quite. And whilst our risk management has improved enormously from when I first got involved with the board, we still have issues of not really understanding how a control or mitigation is making an impact on the risk level. But thanks for the response, Nick.
And I agree, that's where in the deep dives, there's really rich learning into understanding what those mitigations are saying and the evidence behind them. So I fully agree.
Okay, I've got another hands up. I'm going to go to Molly first. Molly, did you want to come in on the last point?
Yeah, thank you, Chair. So I do just thought it's worth acknowledging John's point is valid. John Cunliffe's point around the fact that we need to wait for mitigations to embed. So in fact, we did discuss this at QSE, and we said we needed to see two things. One was evidence, not necessarily the actual evidence, but just an outline of what evidence supports the assertion that mitigations are in place, but also consideration of how long the period is sufficient to evidence that controls are embedded. So that's something that QSE is working on as the risk committee of the board, and that's something that will be reported to the board once we've received the update of that at the next meeting via Lucy's chair's report.
Thank you. Thanks, Molly. Lucy.
Diolch. So a couple of things to me, really. I mean, as Molly and Nick have already stated, we went through the vascular risks and some of the other corporate risks at QSE committee on Friday, where we discussed the need for evidence to be provided before a decision by the committee can be made to approve any de-escalation or change in schools for any of the risks. At that meeting, we also invited a risk owner to attend the committee meeting and go through some of the risks that the committee had been raising questions about previously. And that's something, an approach that Phil Meakin suggested, and something that the committee will be doing going forward. So we'll get more information then directly from the risk owner to actually explain to us how and why they've arrived at the score that they have, but also how they are providing evidence that they are doing their best to mitigate it. Having said that, and what that exercise on Friday actually did was, as Nick has said, it did raise a concern about the consistency of the scoring of risks. I am concerned still that the risks are not being scored in relation to each other consistently across the health board. So whilst the risk owner appears to be, in some circumstances, scoring their risk in isolation without actually considering the totality. And Phil and I have discussed how a more detailed matrix description sitting underneath that scoring mechanism would assist with that consistency of scoring. On that basis as well, and some of the other discussions arising from the committee on Friday, I am concerned that the risk management group has been cancelled again. I suppose I would say this with my as a risk management expert, but I would have thought the risk management group is absolutely not the group that you would want to be cancelling at this point in time, because I'd consider it to be an essential meeting that needs to take place, particularly given some of the challenges that we're dealing with at the moment. Thank you.
Should I come back, Mark?
Oh, sorry.
Jill's got a hand up. Let Jill come in first. It might be easier.
I was just going to say on that point, Lucy, already working with the team to see whether we can reschedule the risk management group and not wait until the next one for all the reasons you've outlined.
Okay. All right. Thank you, Molly.
Thank you, Chair. So I just wanted to add as well, to provide some assurance that we did also realise a bit of learning in the sense that we need to do some quality assurance checks operationally as well, as a risk management function to support busy execs that may not necessarily be cited on proposals in relation to corporate risks. But also I thought it's worth reporting that HBLT has been reviewing risk registers as well. And we're trying to integrate risk management within HBLT because we recognise that risk management cannot just be considered once every other month, a risk management group. So I just thought it might be helpful to provide the rounded view. And that in the period that risk management group was cancelled, we did consider the risk register there.
Okay, just on those 2 points before I come to others, we have yet again entered into a debate about process in terms of this document and also the BAF. We have got to resolve this ongoing dialogue about what is suitable and what is not suitable, whether there is agreement around how we handle these matters or not. Molly and Nick, I suggest you work out how best we resolve that matter. I don't want to come back to this board and have a further conversation about process, scoring and the like, because it is now significantly detracting from my view in what we should be focusing on, and it's the risks and the mitigation thereof. So can I ask that you pick that up outside? Molly, I note the engagement of the IHCs and the management teams, and that is noted on 2.9, and also the fact that we've agreed to be a pilot for the Wandsworth Wales the process, which is at 2.10. Nick, Molly, happy to do that?
Very happy to do so, Chair.
Thank you. The other thing I think we all should expect to see is consistency. The executive team are entitled to consistency across the committees, which is the first point of scrutiny in many respects in terms of a number of matters, including the corporate risk register. So can we please ensure that we are applying scrutiny? Lucy raised some issues on Friday. It seems that QSE, well, those issues should be shared with the other committee chairs, and there should be agreement or not on how we proceed with those concerns. So can I ask the committee chairs ensure that that's occurring? Claire, your hand was up, but it's gone down, so I'll assume you no longer want to come in. Can I then turn us to the recommendations in the paper, wherein we're asked to review, scrutinise and discuss the report? I think we've done that, and to gain assurance that the Health Board's risk management arrangements are effective and fit for purpose. I think I've just alluded to that and some of the concerns that still exist, and I've also indicated how I want that addressed. So if colleagues are happy, I'll move us off this item now.
Okay.
Thank you. So we'll come on to, if we may, the scheduled care update. Nick, I'm not sure who's fielding this. Is it Andrew?
No, Nikki and Andrew Oxby are in the room, virtual room. Mark, if I can introduce it, if you wouldn't mind. So as Nick has outlined, Plan Care has been impacted by the industrial action and indeed by the pressures on our unscheduled care system. And I think it would be remiss of us, as is pointed out, not to acknowledge the harm that is causing to our patients who are waiting way beyond the time which they should be treated, and we have to acknowledge that and own that. So there is work ongoing to try and pull us back in terms of our waiting times for the public for planned care, and we are seeing some green shoots there, and we're having some really good conversations with IHCs as well about how we can improve our efficiencies to ensure that patients are treated both in turn, aligned to the urgency of their particular condition, but working across the health board and indeed working locally to address some of these issues. And the planned care team have been working with them to support some of those conversations, including how we ensure that all our theatres are used as efficiently and our outpatient facilities are used as efficiently as we can, whilst doing some of the insourcing solutions that we need in the short term. So I'm happy to hand over to Nikki and to Andrew to give us a further update, and we'll be happy to take questions.
Okay,
Thank you.
thanks both for joining us. Sorry, Nikki, I've cut across you already. You can take the document as read. So I'm keen that you and Andy, though, have the opportunity to highlight anything that you wish within the report.
Thank you, Chair. Bore da, Nikki Fowkes Dwi. So thank you. So I just wanted to take us back that the planned care journey started with our 6-point plan, detailing themes that we're working with, but obviously knowing the complexity of any programme, we knew that we would be facing. However, any successful programme aren't linear in their delivery, and the constraints have impacted, as Jill has alluded to our proposed deliveries in that. However, what I would like to say is obviously we have passed the first ministerial priority, and we landed where slightly better than where we said we would do for that. I would like to also say that we have, whilst we've still currently got just over 16,500 patients waiting over 104 weeks, that's actually a reduction of over 24,000 patients that have been seen or treated. We continue to do this through targeted interventions, recognising those specialties with the biggest issues, but focusing on the journey into continuing to develop further their models of care, which is linked to new buildings and efficiency. For example, progressing the RTC, OBC and orthopaedic business case, of which my colleague is currently presenting at the Infrastructure Investment and Planning Board. We had said, and I just wanted to flag it, we had said that we would be producing our planned care strategy in February. However, to those constraints that I alluded to earlier, we have low to medium term confidence that we'll be able to deliver that. But I can give assurance that elements that will be within that strategy, we are moving towards and working to, such as the RTC, OBC, the orthopaedic business case, transformation programme, etc., additional activity and clinical pathways. So I'll stop there, and if there are any questions.
Any questions? No hands going up. Nikki, I've got a couple, if I may.
Of course.
The first is that, well, the first is an observation and the information being conveyed about actual against our trajectories and the ministerial targets is, of course, really helpful. I note the variance, and I note the work that's going on to move us nearer to the targets and our own trajectory. And I note that the PCG are looking at internal milestones to drive the organisation in terms of achieving certain targets. It'd be helpful to get an update on that next time in terms of how that's going. Nikki, please.
Sorry. Go on. I was just going to say, I was hoping to be able to give that update of where we would actually land at the end of the financial year, or if we can't achieve a zero position by the end of the financial year, when we would. Unfortunately, we've currently got some technical difficulties of which our informatics colleagues have had to report it to the national team. So as soon as I've got that, I can actually share that to you all.
Thank you. Thanks, Nikki. Jill, Nick, in terms of GIRF and clinical pathways, there's reference to urology. I know that Nick is, amongst many other things, chairing the steering group. I do think the board, I need an update on capacity within the executive team to do what's required and some further information as we move forward about recruitment into key posts that will support Nick and you, Jill, to deliver on some of these programs.
Happy to do that, Mark, as I'm sure Nick is. And I think aligned to that, there are dates in the diary for the coup interviews, which I'm hoping we will have some success with. We're doing the shortlisting as we speak.
Okay, thank you. Nikki and Andrew, can I come to cancer next? Jill and I, not long ago, visited the cancer centre at YGC, and the senior managers there and the network lead were talking about the work going on in respect of cancer and a cancer plan that you referred to in your report. Given our current performance around cancer and the challenges we face, how confident are you that that work is progressing at pace, please?
So the Cancer Partnership Board that is there, and it does continue, although it has been impacted on strikes, etc., to progress that work. There is also constraints within the cancer team, the oncology team, to progress, of which we have asked for a cancer summit to address those. Unfortunately, that has had to be cancelled as well. There are constraints. The team continue to work towards those targets, but there are issues that face that, but we have put plans in place to try and mitigate some of those issues.
Okay, thanks. Nick?
Sorry, Mark, and just to come in to support Nikki, I think there's been a lot of work over the last few weeks around our cancer harm reviews led clinically, which I think is really important because this isn't just about numbers, this is about patients and patients who are waiting longer than we're comfortable with. Also, a lot of work going on to identify the particular pathways, perhaps particularly colorectal and urology, as well as the oncology issue that Nikki raised. The Cancer Partnership Board will be looking at those at our next meeting, which I believe is beginning of February, but the date slightly eludes me at the moment, Chair.
Thank you. Before I come to you, Lucy, I'll conclude what I wanted to say first. Nikki, Andrew, the reference to orthopaedics coming out of the RTCs and the business case scheduled to be concluded in January 2023, and will, as you've said, fast approaching that point. That's quite a major change to the RTC programme. It would be helpful to understand the rationale for that, even though we might be looking to put additional capacity into Llandudno.
I think it comes back to what we were initially expecting to go into those RTCs, and there was always going to be a gap on what we could do from when we moved them out. So there has been a number of proposals, including Abergele, Llandudno, that the team have explored, and that's one of the proposals that would be of more benefit to have a hub for orthopaedics.
Okay, Jill, thanks.
So Mark, I think the other thing, the critical reason why we are going forward on this is timing. So the Llandudno offer, if it's supported, will allow us to bring forward our orthopaedic ambition. And because the way that we're planning to do that, if it is supported, which will be more permanent, that's made us rethink our plans around the RTCs.
Okay.
It will come
All
on
right, thank
board
you.
ahead of the RTCs, and I think that's the critical point that we need to make if the proposal is supported.
Can you keep us in the loop on that proposal then, Jill?
Absolutely.
Please?
The conversation is taking place with Welsh Government today, Mark, alongside conversations about what we can do around more generalised surgical capacity. So yes, happy to do so.
Is it likely to help with the Abergele site, given our previous conversations around the problems we've got with that site, Jill?
So the conversation we need to have, Mark, is, as you know, the infrastructure around Abergele. You'll have seen it through the estate strategy. It's really struggling to put any additional infrastructure on there. So, Mark, if you, Chair, if you're happy, I think giving you a more rounded report post the conversations today might be more helpful than me anticipating.
That would be much appreciated. Thanks. Thanks, Jill. Lucy, you've got a question?
Yes, thank you for the update, Nikki and Andrew. A lot of the challenges that we're dealing with in relation to recovery of planned care will be centred, of course, around our pathways and demand and capacity. A number of areas that I visit are highlighting the lack of space. I went to Memory Assessment Service yesterday and they have 1 clinic room available, but 4 clinicians. I suppose this links back to the estate strategy discussion that we had earlier, and you know the need to make sure that we are maximising the opportunities we have in terms of space. Who needs the clinical space versus who needs operational space? Who can do the things remotely, etc., etc. But the other point then around the pathways is I know the transformation and improvement team are working on some of the pathways, and a question I have asked is how are those pathways being prioritised? Are you both involved in those conversations? Because again, I think we have some quick wins in relation to some of those pathways. Some of them we have made our own problems that we can actually resolve ourselves. And again, that comes out in discussions I have when I visit clinic areas. So yeah, how much involvement do you have in that, and are there any areas that you think actually could be looked at as a priority?
Thanks, Lucy. I think there's 2 things there. I think there is a review within the demand capacity of how we actually deliver our outpatient services, and there is a move away from seeing patients face to face. So we see them, you know, using the virtual mechanism. So there's that element that then frees up estate issues. But there's also, with regard to the team that are looking at the clinical pathways, we've recognised that initially there was perhaps some silo working, but now we're coming together. So we have that, we are able to prioritise what pathways that we can focus on. So say that, and then if there's anything else that you want me to pick up.
Okay, thanks, Nikki. Jill?
Thank you, Chair, and thank you, Nikki. I think it's also worth explaining, Chair, that the work that we're doing with the IHCs to support the planned care team, and indeed with the corporate team, is exactly that, to prioritise which of their pathways are going to provide us with the most impact for those people that we serve. And I think it's really important that we do with this what we've done with other things, which is stream down onto things that can make the biggest impact, and we're working very closely with the GIRF team to do that. The other point, and again Nikki's alluded to it, and the work that Andy is doing is actually ensuring that those for outpatients as well, that those services that need the biggest capacity in order to deliver the desired impact on their waiting times, that will mean some rescheduling, and we know that will need to happen both in outpatients and in inpatients theatres. I know Andy's working really closely as well to maximise the virtual offer where that is appropriate.
Thank you. Thanks, Jill. Final point from me, Nick and Andrew, not for you, I think for Nick. Nick, there's reference to job plans or job planning in the document. When do you think we'll be clear about how we are going to progress that subject from your office in conjunction with the medical directors? I met with one of them, Nick. I'll share some comments with you quite recently, and they were expressing concern about ensuring coordination across the health board in that regard. And I do think there's a significant piece of work to be done there.
There is, Mark, absolutely. And I met the 3 IHC medical directors who are developing their trajectories for implementation of a first round of job planning. We are unfortunately without a live and agreed job planning policy as a result of COVID with the unions. But nonetheless, there'll be round 1 of job planning pragmatically within the principles, and we'll get those trajectories soon. Happy to report that up through PPPH or wherever you feel appropriate, Chair. And then the embedding of a new policy agreed with the BMA, with the local, the LNC, and then a full round of job planning to happen next year.
Thanks, Nick. Jill, you want to come in? If so, we'll keep it brief and I'll move us on again.
It's just to support Nick. I think critically the work that Andy and Nikki are doing with the IHCs to define where we need the most capacity will help support that job plan as well. So they're working very closely with the work that Nick is describing to ensure that the job planning meets the needs of our patients and our services.
Okay, cheers. Nick, as you've offered, an update through PPH would be helpful, please, when you're ready.
Thank you, will do, Chair.
Molly, and then John, I want to draw this to a close, so can you be brief, please?
Thank you, Chair. So it was just to highlight a point of clarification for the board. On page 8 of the report, there's description of a risk relating to waiting list, which has reduced to 20. So it was just to clarify that actually we discussed at PFIG that we need to revise this risk in light of a related risk around loss to follow-up. So I just wanted to clarify that this risk is not necessarily reduced. So it's been flagged to me by an IM.
Thanks, Molly. And I think as I've alluded, I need to review those. So we'll pick those up. Thank you.
Thanks, Nikki. Okay, Nikki, Andrew, thanks for coming along and fielding the questions. Much appreciated. And we much appreciate the work that's going on, being led by you two in terms of plan care. So thank you. Thanks very much.
Thank you, Chair. Thank you, everybody.
Right, I'm proposing that we have a comfort break at 12 o'clock when there's a planned change of translator. So with that in mind, I'm going to take us to the winter resilience item. And once we conclude that, we'll go to a comfort break. So, Nick, please.
Sorry, Chair, having a moment there, unmuting. I think the majority of issues in the paper are probably already acknowledged, Mark, in other conversations, both in Jill's report, the CEO report, and in the unscheduled care. Perhaps I would just highlight that we have heard at previous health board meetings in September and November that there will be a winter plan for signing off at the board. This is predicated on receiving the winter health and social care plan from Welsh Government. And it now feels in many ways that as the winter plan is being used, updated on a live basis, as we've already heard, that sign off, having still not received that national information, becomes in some ways irrelevant. But you will see in the paper, and would welcome any feedback, that we will propose to bring the winter plan for 23-24 to the health board for local sign off in September this year. And whilst that might whilst not wait for national guidance, because whatever the national guidance is, we need to have our plans and be assured that our plans are ready for winter in the next winter. So there is not, I'm afraid, Chair, a winter plan for sign off today for the reasons stated, but I think we outline in the paper the work ongoing and the proposal to bring it back in September next year rather than waiting for national guidance. I hope that's acceptable. Happy to take any questions.
And you have detailed separately in presentations to board workshops the range of the work being undertaken this year in terms of winter pressures. So it's not as though you've not provided the board with further and more comprehensive information than is contained in this report. But I'm sure the board, certainly I would welcome September as being the time at which we see a winter plan. After all, it's to be expected, isn't it?
There may, Chair, be a requirement to include the winter plan in the IMTP planning process. So it may end up, depending what that looks like, that we do have a locally agreed winter plan, which I'd still be very keen to bring to board. And then there may be another document required at a point in time that's related to national planning policy.
Okay, thank you. So there are no hands up, Nick. So the board is requested to note the ongoing work with an awareness of the national steer from Welsh Government. Are you happy to note the work that's ongoing? I would assume that's a yes. Okay, so we are now going to pause the meeting and have a comfort break. And I'd ask that you be back, please, at 12:05. Thank you.